Hello, everyone. We're here today with Doctor Megan Turley. She is a fellowship-trained colon and rectal surgeon with a comprehensive robotic surgery practice in Austin, Texas. She works at Texas Colon and Rectal Specialist in Austin.
Thank you so much for having me.
Yay. I'm so excited to talk about hemorrhoids today. I know how excited you are.
The most excited.
Yeah. Talking about buttholes and all that stuff. Poop. All the things. I'm sure you hear a lot of poop jokes all day. Do you know?
Yeah, I hear some good ones and some that are basically like poop, but that's mostly for my kids.
Oh, okay. That's hilarious. I saw like the little like poop.
My like toys and figureheads. We have a lot of those.
Yeah.
Around.
Yeah. So fun.
All right. I'll tell you a joke then.
Okay. What's up?
A man presents to the emergency department with 5 plastic horses in his rectum. His condition is described as stable.
Oh my God. I love them jokes. That's amazing. Oh my gosh. I love that. Okay. Well, we can sprinkle more of those in as we go. But all right. Okay. So we have a question from Kate in Greenville, South Carolina. She says, I have some stubborn hemorrhoids that are not going away. What can I do about it? So let's kind of, that's just an open-ended question. Yeah. So can you describe to everybody like what a hemorrhoid is?
Absolutely. The very first thing you should know is that hemorrhoids are like arms. They are anatomic. Everyone has them. They are vascular cushions in the anal canal. The function they serve, it tends to be both providing kind of moisture and mucus in the anal canal, as well as doing what's called anal sampling. So sometimes people don't give the anus and rectum enough credit for the job they do. But I want you to consider, probably even within the last few weeks, you've been in a crowded place with people you respect, and you decide you're going to eke out a silent fart. Now, in that moment, the nerves, muscles, and your brain have to decide, is this gas, liquid, or stool? Is it going to be loud or is it going to be quiet? So your butthole has to figure that out, or else people would just be shitting their pants in public. I'm sorry, can I say that?
Yeah.
Okay. People would just be shitting their pants in public all the time if they were wrong.
Yeah.
Right. So now those signals can get messed up in different types of anal rectal pathology. So for people who have thrombosed external hemorrhoids, who have hemorrhoid crisis, all those things can get a little bit mixed up. But anyway, that's the term anal sampling, is the ability of your body to know, like, is this an okay time to try and squeak this out? Or am I about to have like a big emergency here?
I think this sounds so funny. I saw something on Instagram the other day and somebody was like, it was a door and the door said like butthole. And then it said, it was like a fart. Somebody was like, I sure it said fart. And like the fart was like getting ready to go out the door. And then the guy was like, sure it said diarrhea and it like ran out the door first.
Oh, yeah.
So it just made me think of that.
So essentially anyone who comes to my office to talk about hemorrhoids, I really listen to what the actual symptoms are, because essentially for most people, unless you're a proctologist or a GI doctor, hemorrhoid really just means like there's a problem with my anus. I can barely eke the words out to tell you what it is. And so our job in proctology is to really figure out like, what are the symptoms that are bothering you? Yeah. Because most of the time, if hemorrhoids aren't bothering you, they certainly don't bother me. Now, as far as the anatomy goes, so hemorrhoids, benign, do not cause any problems long-term, but kind of with the exception of like torrential bleeding or what we call audible bleeding. That's where people tell me they're like, I sit on the toilet and I can actually hear blood hitting the water. So that's kind of like a different set. So hemorrhoids, internal hemorrhoids and external hemorrhoids are kind of the way we designate, and it can kind of help you understand what the symptoms are. So internal hemorrhoids are up in the anal canal. They tend to get big and engorged when sitting and straining. They can bleed and they can fall out your butt. That's called prolapse. So that if you sit and you bear down and have a big bowel movement and you feel like as you're wiping, you're pushing tissue that belongs on the inside back up into the inner canal, that's hemorrhoid prolapse. External hemorrhoids are made of skin. Your anus or your butthole is made of skin, just like the skin on your hand. It's squamous tissue. It's highly innervated, very sensitive for better or worse. And so when people have external component of the hemorrhoid, that can be both the vascular involvement. So tissue that gets bigger and smaller based on your bowel habits. If you're sitting and straining, if you're hiding from your kids with your anal canal unsupported over the toilet bowl while you finish that last YouTube video, or you're texting your mom and you just want to get that final thought out. And then when you wipe, you're like, my God, are these grapes? No, it's just your hemorrhoidal tissue filling with blood because your canal's unsupported at that time. Yeah. Now, because it's made of skin, that actually belongs on the outside. So a lot of people tell me like, oh, I have hemorrhoid prolapse. I have tissue that's not supposed to be there. Well, external hemorrhoids are supposed to be there. That's skin. It lives on the outside. Now, whether or not you like how much skin there is or the vascular component, so whether or not it gets bigger and smaller when you're sitting and straining, like those are things that are modifiable. But just the mere presence of tissue on the outside of your anal canal is pretty normal. I have a speech in my office. It's called Every Anus is a Flower and All Our Petals Are Different. Oh. And I won't go into the details, but essentially it just means that like buttholes are different, and buttholes can be different when you're young, when you get older, if you practice anal intimacy, if you have lots of babies, if you have surgery, if you get infection collections next to your butt and you need surgery for that. Bottoms just look different over time. And there's nothing wrong with that. If you're having symptoms, that's when we want to see you.
Yeah, I say that too about vulvas. You know, it's like everybody's vulva is different. I have a lot of people come in and like, my vulva looks weird. It doesn't look like anybody else's. I'm like, well, where are you getting this information? And see that either usually like pornography or something, or just anatomical pictures in an anatomy book. And everything looks perfect in those things. And the reality is, like you said about buttholes, is like no one's is the same. Everybody's is a little different. And I think the more we normalize this and talk about it, like, hey, like we all have them.
Yes, absolutely. And truly, unless your partner is a proctologist, they probably don't notice or think anything about your anal opening other than they're excited to be there because that's something you guys have chosen to do.
Yeah. Yeah. Around the holidays, I posted something on my Instagram. It was like, everybody has a butthole, but don't be one.
Yes.
So that was nice.
I love that.
Or asshole, I guess, whatever. Yeah. All the same. Okay, cool. So why do they happen? So you've basically said how, this tissue is normal, but then, it's highly vascularized. So that means increased blood flow and all that stuff for people that don't necessarily know what that means. So why, what are some common reasons?
Sure. So everyone's body's a little bit different. And so some people are predisposed to having troublesome hemorrhoids and some people are not. I really can't tell you kind of in your families, like who will or will not be. However, there are some things that do put people at risk. So constipation and diarrhea can give people hemorrhoidal troubles. And that can either be engorgement sensation at the anal opening. It can be lots of mucus. It can be tissue that falls out that you have to push back in. It can be bleeding with wiping. And it can be that external engorgement component. Now, some people in the setting of straining, and I mean straining in any sense, so straining to poop, straining to move a piano, straining in the setting of like moving a hot tub, straining when you get sick and you're throwing up a lot, all those things can change hemorrhoidal components and can kind of precipitate them being more bothersome than other times. Pregnancy, also a big one. Unfortunately, not just big old baby heads, but the hormonal changes surrounding pregnancy, surrounding things like IVF, surrounding things like breastfeeding and weaning and menopause, all of those hormone changes can change the way that our stools kind of form and evacuate. And those can all kind of precipitate hemorrhoidal troubles.
Do you think it has more to do with estrogen, or what do you think the hormonal components do?
So yes and no. So it's a combination of estrogen and progesterone, and our gynecology colleagues could probably get a lot more sexy in the weeds as far as the descriptions about which are more constipating at one time or another. But because hemorrhoids can be exacerbated by all types of hormone changes, then I'm not going to specifically assign to one or the other.
No, I mean, it makes
don't point fingers.
Yes, don't point fingers. I think hormones get like a bad rep too. Especially estrogen. Like, there's never absolutes,
Right.
It's just understanding that. But Yeah, I think that there's almost a lot of embarrassment, especially postpartum, with people saying, "Oh my gosh, I have hemorrhoids." Like, I'm like, you know how many other people have hemorrhoids that come in here and they mark it on their paperwork, but they're not shouting it on the rooftops. I mean, people aren't talking about this on social media and stuff like that. And so, yeah, so it's pretty, I don't think it's anything to be embarrassed about. I mean, it can be embarrassing because it's your butthole, but also, it can happen to anybody pretty much. And apparently moving pianos is a big thing.
I see people, holidays, piano moving, all things that have.
Do you think that's just kind of like the force, the abdominal pressure, and just that bearing down,
the bearing down
pressure on the tissue,
and then the Valsalva motion? So we call it kind of breathing against the closed glottis, which means like when you that I didn't even blame my weightlifters. I see lots of people who are trying to make lifestyle changes, who are coming in because they've just started trying to either quote unquote get jacked, right? So taking higher protein powder plus heavy lifting without good breath control. And I can see those kind of causing different hemorrhoidal stuff as well. That being said, treating hemorrhoids, it starts at the top, right? So the things that you eat affect what comes out. So spicy in, spicy out. If you're not eating kind of a variety enough fruits and vegetables, things like that. So I have all my patients start on a fiber supplement. I take one myself. I am fiber agnostic. I do not care about brand or whether you go the geriatric generic route from your local pharmacy, or whether or not you get in the weeds with the millennials and do Ollie Pop water or whatever. Just as long as you're hitting that 25 to 35 grams of fiber in a day, that's what's going to try and kind of attenuate that difference between constipation and diarrhea. So that's the place that I start. And it's pretty incredible how much that makes a difference for hemorrhoidal symptoms of engorgement, bleeding, and prolapse. Really, really, really helps. So much so that I have people come into their follow-up just to tell me that they were surprised that it worked.
Yeah, I think that's great. I think also, understanding the mechanics behind it, right? I think where people don't understand is, okay, well, I have a hemorrhoid. What am I supposed to do? So kind of with the recommendations with the fiber and things like that. But then also, you were saying, the closed glottis, just understanding breath. So closed glottis is basically when you're holding your breath and you're not letting anything out. But if you can do it, if you hold your breath with a slow exhale, basically that is taking off some of that pressure. So if you are starting to work out more and you're noticing more of these symptoms, it's not necessarily saying to stop. It's just more of, hey, as we take on new routines, new diets and nutrition and things like that, our body's shifting. So kind of being more gentle with yourself and understanding, okay, well, what switch? What are some exercises that I'm doing that I feel like I'm straining more? So from a PT perspective, I would say, which ones are you straining on the most, right? So maybe we either decrease that weight and then slowly build you back up, or we try a slow exhale when you're doing it, and then kind of seeing how you're feeling with that aspect. And then also diaphragmatic breathing. So you get the diaphragm that helps push kind of everything down and relax your pelvic floor. And then as you exhale, everything comes back up. So we've talked about diaphragmatic breathing in previous episodes, and some of the videos are on my Instagram and stuff. But the point is that, all of that stuff. I think that's awesome. And so fiber is a good one. And what, people, I think when people hear hemorrhoids, they're just oh, preparation H. What is that even what are your thoughts? Give me it all.
So for acute hemorrhoidal problems, so bleeding, prolapse, itching, pain, you can spend $1 million on the aisle in the pharmacy, and you probably be just as good making a poultice out of that bill and applying it to your butt. It's this stuff just doesn't work. So what works when you're having hemorrhoid troubles? In a short duration, so less than 2 weeks, you can use things like Preparation H, topical lidocaine. That's kind of a numbing medication. Honestly, what people tell me works the absolute best is sitting in the hot bath. Relaxes the muscles of the pelvic floor, decreases that inflammation and the itching sensation. You don't have to put any special salts or anything in there, but that's a really good place to start. A lot of people get muscle spasm along the anal canal in conjunction with hemorrhoid troubles. So medications like ibuprofen can be really helpful, probably even more so than Tylenol, although you can take them both at the same time in these settings. Prescription steroid suppositories really are the most helpful in an acute setting. What I tell people is like, if you get a mirror and you look and you're like, I don't even know where my anus opening is. Make a guess, put the suppository as high up as you can, because the entryway for all of that engorgement and fullness is going to be higher up in the anal canal. And so smearing it all over your anal skin isn't going to do a whole lot of good, but getting it more up in the anal canal can be really helpful. So like when having troubles with hemorrhoids, sit in the hot bath, Tylenol, ibuprofen, steroid suppositories up high in the anal canal, numbing medication often before you use a bowel movement can be helpful. So that's like your lidocaine that's even over the counter. And then don't get constipated. So use your fiber supplementation and your laxatives. One thing that people find helpful is to try to differentiate your bowel aisle in the pharmacy, which is going to be at a risk of being crass. It's going to be the fluffers and the pushers. So the fluffers are going to change the caliber of your stool. Those are things like powdered fiber supplementation, which I think is better than gummies or tablets or things like that. I don't have any evidence. I can't point to the scientific paper that says that, but kind of anecdotally in our society, that's what we believe. It also guarantees that you're drinking 8 ounces of water to try and get that in. So once you take your fluffer, you need to drink it with plenty of water, or else you're going to poop out a fiber brick. Then you can discuss whether or not you need a pusher or a laxative. So those are things with lax in the name, Dulcolax, Miralax, and those over-the-counter type things. Those help you kind of stimulate the bowels to move and can be really helpful when taking in conjunction too.
It's about water.
Yeah.
Water intake.
Yeah.
I think water and exercise, like movement.
Yeah.
I
Move your
have
body.
People do like pelvic mobility. Just kind of almost look like they look in the mirror, like raise your hips up, hike your pelvis, rock back and forth. I mean, your colon is lined up all along your abdomen. And so getting all of that moving too, and even just walking, I think that, in our society now, there's a ton of sitting, less exercise, and a lot of caffeine, right? And so, hey, she's hiding her coffee, but I am a huge advocate for, I love coffee. So I'm not saying anti-coffee stuff, but what I'm saying is like, getting people to kind of think like, okay, what are some other things that I can be doing that can help us? Bidets.
Huge fan of bidets. So when people come in saying like, oh, I have a hemorrhoid problem, oftentimes it's actually not anatomically a hemorrhoid problem. It's a constellation of symptoms, right? So anal pain, anal itching, excess tissue, moisture changes. So bidets are awesome for doing a number of things. So if you have anal itching, treat your butt like a baby butt. Stop putting product on your butthole. Go to exactly what you do for a baby, right? Do you just take a giant poop? Gentle soap and water or a bidet. Quit wiping so hard. The bougie wipes that are kind of marketed to people as like some sort of anal hygiene, really more of a self-cleaning oven. So gentle soap and water, minimizing product, easy on the wiping, those micro tears that you get using toilet paper and being vigorous can lead to these like very small excoriations on the skin, which perpetuate this itch cycle.
Well, it's funny because it's like, even when we're just like talking about poop, right? We don't even have these conversations. Like, and even talking with the vulva, it's like, how can you even clean it, right?
Mm-hmm.
So people are like scrubbing it with their loofahs, and then like there's bacteria in there, and just use water or some like soap. The same thing like when you're wiping your butthole. Be gentle.
Easy does it.
Easy, tiger. Easy, tiger. But like I'm a huge fan of that, like, you don't have to go out and get this huge thing at your house. You could I got one off the Amazon for like $30.
Yep.
And you put it on. I accidentally turned it up super high once. And I was like, I'm pretty sure that probably gave me a hemorrhoid or something. Or something. I don't know. But anyways, the point is like, those aren't great too. And like if you're traveling or something, those
Perry bottles, the spray bottle you spray your cat with, totally fine to use on your butt.
Yeah.
Like when people train their cats, they like,
oh, I didn't know that was a thing. That's cool.
I don't have a cat, but I just heard that like, if you're like, no, get off that.
Oh, I see. Okay. Well, or like if you're traveling and you don't want to bring the Perry bottle, you like just those like wet wipes or something like that to kind of help. Oh, I just think it's so odd how much toilet paper we use. Like during COVID, when everybody was buying all that toilet paper, I was like, is everybody giving themselves hemorrhoids at this point? Like, I wonder if there's a huge influx of hemorrhoids.
They didn't make it to the office.
That's true. Yeah.
What I tell people when you talk about butt stuff is I'm going to propose a toolkit, right? And then you choose how many things out of the toolkit you're going to use in a given day, in a given scenario, right? So like, oh, I can't use a bidet because my work doesn't have a bidet. I work in a proctology office and I don't have a bidet here. So like, I get it. Google probably doesn't have it. I don't know. Maybe Google does have a bidet or Apple does.
I've actually never been anywhere that has one, except for my house.
I haven't been either.
Yeah.
For things like, I tell people, you should take fiber, take your fiber supplement daily, take a laxative as needed. Yet don't take a giant amount of Miralax and then go to work. That sounds incredibly uncomfortable if you are a driver so time it, think about it.
Yeah.
Fit it into your day in a way that makes sense. I can't prescribe agenda that's going to work for everyone. So it does actually take a little bit of work to like know thyself, know thy body, and know whether or not when I give you fiber and Miralax, if you're going to poop on your commute. Sorry.
No, you shouldn't do it before like a 10-hour plane ride and like just clog up the toilet. No, it's the same. I mean, it really goes with everything else. It's like understanding how to manage your symptoms and why.
Mm-hmm.
And if you're more susceptible to them, you start learning like what's in your diet, exercise, pelvic mobility, hip mobility, breath work, learning how to relax your pelvic floor. There's different stretches you can do for that. Like you were saying, just like spasming around the anus. And it's funny because when people come in for PT, sometimes they're referred by their doctor and they're like, I don't know why I'm here. I'm like, oh, okay. Like I get it because there's a lack of information.
Yeah.
And then I explain all this and then they're like, my gosh, that's crazy. And the other thing I'll see too is like when people are really stressed out, right? And eating really fast and not digesting. So their body's in that fight or flight. So the digestion slows down and that all starts in the mouth.
Yep.
I think people don't think about it. I mean, until I was into pelvic floor PT, I didn't think about it. I mean, I hardly took lunch breaks. I just swallowed things whole. And I was like, why am I bloated and constipated all the time?
Yes.
But yeah, so that's funny. Anyway. All right. So what are some so we just talked about some non-surgical things that people can do at home. So say they do those things and, it's just not getting better.
Right.
What are some, so they can come in and see, hypothetically, if they're not, they can come see you.
Yep.
What are some in-office procedures or like, what are some things that you could prescribe for that next level?
Sure. So I'll just give kind of like a brief overview of what it's like to come to a proctology office. And what I try and do very much in my practice is making the appointment the most painful thing, right? You finally decide I've had enough. So come to the office, obviously paperwork, blah, blah, waiting room, looks like everyone else's waiting room. Come into the office, we meet, we have some like cursory chat. What are your symptoms? And almost everyone says like, I have a hemorrhoid. I'm like, well, what does that mean to you? So is it bleeding? Is it itching? Is it redundant tissue? And then after we kind of get a sense of what your symptoms are, then I do an exam. The way I do an exam is first I look on the outside. So looking at the anal skin, looking for things like infection collections, which are pretty rare. Usually if someone has a big sore in their butt, they know about it. They tell me about it. Looking for things like fissures, which are small cuts in the anal canal that can cause an extreme amount of pain during bowel movements. I have to credit a dear patient of mine who described it as like pooping a pineapple, right? Like real spiky, real sharp while having bowel movements. So I look for things like fissures. Then I look at the caliber of the external skin. So is the external tag, is it part of the skin itself? When I retract or pull on it, does it bring down internal hemorrhoid tissue, kind of concerning for prolapse? Are they all over, like circumferentially around the anal opening, or is it in one location versus another? Is there thrombosed external hemorrhoid, which is a blood clot on the outside in that skin? Those are extremely painful and they look really tender. And then after that is a digital rectal examination, which is an examination with the finger. So finger in the bottom, feeling for any masses or irregularities, nodularities, changes in the mucosa, which is the tissue lining the rectum. I always feel for muscles of the pelvic floor to evaluate for tenderness there or pain. And then I use a small scope called an anoscope. It's just a couple of inches long, just a little bit bigger than my finger. And it has a side slit that allows me to look at the hemorrhoidal tissue itself. Everybody's got some element of hemorrhoid tissue. Some people have big, bulky hemorrhoids. People with big, bulky hemorrhoids who it doesn't bother them, then it doesn't bother me. Nothing to do. But if they're like big, bulky hemorrhoids and they bleed, big, bulky hemorrhoids and they fall out. So for internal hemorrhoids without a significant external component or an external component that doesn't bother you, you can do things in the office like rubber band ligation. And essentially what that is, it's like if you put it like a hair tie at the top of a plastic bag, right? So the tissue, there's tissue on the outside and tissue underneath it. It cuts off the blood supply to the extraneous tissue, which then falls off with your poop in a couple of days. Most people tolerate it really well. Women tolerate it awesome because they understand that you can bleed and have a little bit of pelvic pressure and you're not dying. But male patients take a little bit more counseling.
Yeah.
Usually, I'm a very conservative surgeon. And so I usually place one and see how people do. I say, go home, hang out. Don't ride on your Peloton. Don't, go on a family horseback ride tomorrow. But pretty much other than that, you can do whatever you'd like. If that resolves the symptoms, awesome. Not usually the case. Usually it takes a couple treatments for banding of internal hemorrhoids. Then I have people come back in about 2 weeks. If they say, yeah, it really helped, but didn't resolve, then we can place kind of 2 or 3 more bands at that time to see if that resolves the issue. Usually I give people about 2 or 3 sessions to declare themselves, right? If you have all of your symptoms resolve at that time, then we're done. If I find myself banding you into oblivion, like you're coming in every few weeks and it's still bleeding, that's just not working. And we need to start using another tool. We can talk about the external or the excisional method after this. Other therapies people do, infrared coagulation, sclerotherapy in the anal canal, hemorrhoid ligation. There's a bunch of different other strategies. Personally, I think that hemorrhoid banding is easy, well tolerated, done in the office and quick. So I use that as my in-office modality. Now, for externals, I kind of include that under the heading of anal landscaping. Changing the topography of your anal opening. So for people who don't really have acute hemorrhoid issues, but they have redundant external anal skin, either as a souvenir from a prior hemorrhoid, things like that. So yes, you can excise these. The risk is that the skin that grows back or the way that it heals is not version 1.0. It's version 2.0. It looks different. It feels different. It functions a little different. Most people tolerate it really well. But if you make tags, you'll continue to make tags into the future. And so sometimes cosmetically, you just have to make sure that you understand that
it may come back. It just may not be.
It'd be different. Yeah. Your anus skin will look a little bit different. So those are in-office based procedures. So for people who have substantial internal and external hemorrhoid together, so usually in 3 columns, sometimes 2 columns are more dominant or 1 column's more dominant.
Can you explain column?
Oh yeah. So column means the internal and external component together. So these are in lines that run up the anal canal from the outside to the inside or the inside to the outside, depending on your perspective. So for those people, hemorrhoid excision is kind of the way to go. And what that is going all the way to sleep in an operating room, lots of numbing medication, and then using a cautery of some sort to excise the tissue and put it in the bucket. Some people sew the defect closed, some people leave it open. What I counsel patients is that it works great, right? By the time you are recovered, you are no longer prolapsing internal hemorrhoids. You're no longer bleeding. The external component is much reduced. Sometimes you have to get some detailing work later on, but it's extremely painful. Mm-hmm. I tell people take 4 weeks off of work. That's a long time.
I think people don't realize how long that is. Yeah. And cauterizing is basically just kind of cutting off the blood flow.
Cutting it off with heat. Yeah.
And so people know what that is. But I think that there is this assumption that almost all of a sudden you just need to go into surgery immediately because they're embarrassed or whatever. Like you're saying, it's like you can have a hemorrhoid and not have symptoms. And it's like this also with vaginal prolapse too. Somebody can come in with a small prolapse and have so many symptoms. Mm-hmm. And I'll see somebody with a pretty significant prolapse and didn't even know it was there. Mm-hmm. They found out because of their OB or they just felt symptoms or they didn't have symptoms, but maybe their back pain didn't get better. Yeah. And we were like, okay, well, let's look at let's look at the pelvic floor and see what's going on there. But yeah. Do you think, I just think silent farts are so funny, but they're so smelly because they're literally silent but deadly. What can that cause hemorrhoids if you're like secretly farting all the time?
No.
Oh, I thought that's where that was going. Because I was
wish.
like, wow, I didn't know that.
No.
So everybody stops. Just let it out.
I don't think so. No. No, it's just a tribute to the extreme sensitivity of that neuromuscular system.
I thought that's where it was going.
My parents are going to be so proud of this.
You are literally a rectal surgeon. Like, what are the next steps?
I think they like to think about the complex rectal cancers that I'm curing with the robot, right? I think they like to think about that aspect of my job, like curing rectal cancer, colon cancer, big abdominal surgery, like healing people with Crohn's disease. That's what they like to think about. Not like, did you hear a podcast on farts and
well, yeah. I mean, you're doing all those amazing things too. And we can definitely talk about that in another podcast if your family's embarrassed. I was just thinking more from like a pelvic floor perspective, which also, you know, I've had people come in after rectal cancer and do really well.
Yep.
That, you know, just the inability sometimes that inability to kind of know if you're about to poop or fart and you don't know. And so learning that it's the biofeedback and just understanding, hey, what's this new sensation that I'm feeling too?
It's a huge part of my practice. The sexy make your parents proud is curing cancer, right? But the entire purpose of doing any medical intervention is that people need to then go forth and live their life, not just be alive. And with people who have debilitating proctologic symptoms, they can't do that. Right. So people who have fecal urgency can't go on a run with their friends, can't go to the movies, can't go on a plane like that. And it's amazing how much people suffer with that. And then I do have another soapbox that I have to get on.
Sure.
We have this cultural phenomenon of cleanliness and godliness. And so people truly feel like deep amounts of shame that if there's something wrong with my butthole, it must be related to me not being good or clean or holy. Like all of these things can like come into play, and it doesn't necessarily have to be conscious, but the amount of shame that people carry with them that prevents them from coming to the office or seeking care. Like this, I can help you with this. This is easy. This is good. We can take care of this. It has nothing to do with your morality or your cleanliness or, you know, if you have leakage or seepage, like that is not about morality. It's about your biology, and it's like giving you a hard time, but we can make that better.
Yeah, exactly. Well, it's because it's taboo to talk about this stuff, and especially for women. It's like,
because you're supposed to be clean.
Yeah. Oh my God.
You're supposed to be good. Roses. Right. You're not supposed to poop.
Don't yours smell like roses?
Mine do, but that's a separate appointment.
Yeah. No, I think that even people coming in for pelvic floor PT already know that there's something on that's like, especially with rectal prolapse, which is, we can talk about another time. Basically, you know, when the rectum falls more into the vagina, I'll also see people say that, you know, they wipe, and then they're clean, right? It's clean. And then, you know, 2 hours later, they have poop stain.
Yep.
And they're so embarrassed. I'm like, okay, first of all, everybody's had a poop stain. I'm sorry. Everybody has sharded at some point in their lives. Like it just happens. It's more of,
and the fiber helps with that. If you have a rectocele, if you have sticky poops that get caught on your external hemorrhoids, the fiber really does help with that and the cleanliness part.
Yeah.
Just for a laundry's sake.
Yeah, no, I mean, and there's a lot of shame around it, and it's almost like socially acceptable for men to talk about it. You know, like I've always been a big talker about poop. To the point where like growing up in my family was like, I'm like a lady. I'm like, oh, I don't.
You're like, I am. Guess what? I have the biology to do this.
Guess what? You poop too. You poop too. Everybody poops. Everybody poops. But yeah, I mean, and yes, I want to make sure everybody knows that you do more than hemorrhoids, right? And you want to go through all the things that you do treat. Just so people know.
Yeah. So a colon and rectal surgeon does surgical management of diseases of the true colon and the rectum. So from the right colon, including the appendix, all the way over to the sigmoid colon and the rectum and the anus and the anal opening. So that includes things like cancer, inflammatory bowel disease like Crohn's and ulcerative colitis. It includes things like diverticulitis and diverticular surgery. We do emergency surgery. We do elective surgery. And we do comprehensive management of rectal cancer, working in tumor boards to make sure people are getting kind of the best guideline-based care in a disease that's incredibly complicated. We do the post-operative management and surveillance. So things like looking at new plumbing connections that we make surgically, making sure there's no recurrence of cancer or recurrence of disease. And then kind of what brings me on this podcast is talking about, what is proctology? Like, what are the ways that your butthole can give you frustrations? And what's worth noting is that a lot of people just say like, oh, I have bleeding. That's a hemorrhoid. Like, you gotta get looked at. It's not normal to bleed from your butt. It's not normal to bleed from your butt, period. It's not normal. And so for people who have ongoing bleeding, you gotta have a conversation with your medical provider. You gotta get a colonoscopy. Gotta make sure that you're taking care of yourself so you can be there to take care of your family. Symptoms like rectal bleeding, rectal pain are all things that, is it probably a hemorrhoid? Yeah. But in some people, it's not. And I would hate for your symptoms to be written off as just a hemorrhoid when there's something else that needs to be evaluated.
Well, I think that's also what it is. I was talking to a client earlier and she was like, oh my gosh, I have a hemorrhoid and I'm so worried about it. And this person I know, they waited and then they found out it was cancer.
Mm-hmm.
And so I find people jump to cancer all the time. And so what is the biggest distinguisher? I mean, obviously people need to get it checked out in general, but, when I see too, especially with like colon cancer becoming much more up your sleeve.
Oh my goodness.
Much more. I know this is a little off topic, but it has to do with hemorrhoid and anal health, basically.
Right.
And so if we're not understanding this and just embarrassed to ask, it's like, I mean, this is what people like you see every day, doctors like you and surgeons.
Yes.
So
you have to be, I truly, there is no one that I've given an award to for surprising me.
Yeah.
I'm not going to say you can't surprise me. Certainly one of you out there could. I would be very excited to meet you, but really like, so much is normal.
Yes.
You are normal.
Yes.
You are normal.
Yes. Because you are normal. And, you might feel a little embarrassed, but, hopefully hearing the way we're talking about this is making it a little bit less taboo and less scary. I mean, literally your Wi-Fi password starts with poop. And so it's like, you have to have fun with it.
Yes. Yes. And your problems are not unique. We just haven't done a great job of branding, right? Like the appendix, great job, appendix team. Congratulations. Gallbladder, great job. Everyone's like, ooh, had to go to the hospital. Cholecystitis, got my gallbladder out. Like, oh, you can say that. You can say that during Thanksgiving. And your grandma would be like, I also have a gall, right? But other problems that are so much more common around things like hemorrhoids, anal pain, fissures, urgency, seepage, fecal incontinence, all those things are far more common. We're just really bad at branding. So,
well, it's literally digestion.
Mm-hmm.
So it's like, we're more open to talk about throwing up. Like, oh, I vomited.
Mm-hmm.
I got sick.
I have an upset tummy.
Yeah. Versus like, oh, I have diarrhea. I honestly, I love it when somebody is so open about it. Like, sorry, can't coming out. I've got diarrhea. I'm like, I am fully on board with you just being so open about that. And yes. But I mean, it's digestion and it's literally food you just ate and, hours ago. And it is just like peeing just out of your butthole. Well, you should be
similar
out of your butt.
If you're peeing out your butthole, I also would like to see you.
Yes. But what I'm saying is like what comes in comes out.
Yes.
And it's in the form of poop out of
Yes. And it's biology and it's great. I mean, that's how these body machines keep working. I think we're going to talk about how like who has a hemorrhoid and who has cancer.
Yeah. Yes.
So the most honest way I can answer that is come and get evaluated. Mm-hmm. And you can have hemorrhoids and cancer. So if you are a human and you are an adult colon and rectal cancer is extremely rare outside of familial syndromes in teenagers and young adults. That being said, I have a patient panel that includes people in their early 30s with colon and rectal cancer. And so if you are bleeding, you need to be evaluated. Usually how that goes, if someone comes to me with rectal bleeding, we try some conservative management, right? If I can cure your hemorrhoids with fiber a day and you come back and say, I am no longer bleeding and I'm 25, we can do a jumping high five and you can go on your merry way. But if I have not resolved your bleeding with conservative intervention, right? So try the fiber, that didn't help. We do a band, that didn't work. You are on your way to colonoscopy city. So I can tell you with certainty, it's just your hemorrhoids bleeding. It is not an uncommon scenario that people come to the office for what they believe to be hemorrhoidal bleeding. And the colonoscopy says, yes, you do have hemorrhoids and you also have a cancer. And so that does need to be evaluated too. And we're really good at working with people to get access to those types of studies. So all my colleagues are very attentive to it. You should not be written off as just hemorrhoid bleeding. If we can't make your bleeding stop, you need a colonoscopy.
Yeah. And if you're not in Austin and you're being dismissed and you're like, something's wrong, please find another provider. Find somebody that will listen to you. I can't tell you, even me being in the medical field, how many times I've been kind of gaslit and just like, oh, you're fine. You're fine. I'm like, I'm not, and it's important that we advocate for ourselves.
Yeah. No. This is kind of like a half lie, right? Where I'm going to say no one's going to be offended if you seek another opinion.
If they are, I feel like that's weird,
I totally have had hurt feelings when people don't want to see me anymore. But at the same time, I'm like a bit like,
well, I mean, that's human nature though. It's like, not everybody's going to get along with you. Not everyone's going to get along with me.
Yeah.
Yes, it hurts, but it's also like, obviously there was something in me or what they were wanting was not what I was providing.
Yep.
But the reality is ultimately they're getting the care that they want. Yeah. And,
yes. And then the other thing is screening. Colorectal cancer is identified on screening. And so our current guidelines as of 2021, if you're 45 years old with no symptoms, please go get yourself screened. Get yourself screened with a colonoscopy. And, my proceduralist bias is that a colonoscopy is the way to go. I think the benefits certainly outweigh the risks of the procedure, specifically with regards to polyps and prevention of cancer into the future. So we can remove polyps at the time of colonoscopy. While not all polyps grow up to become cancers, almost all cancers started out as polyps. That is different than doing something like a Cologuard or a poop in the box or a blood test or things like that are sometimes offered as equivalent screenings.
Yeah, that's what I'm going to ask you because I've heard people say like there's this pill that you can take and then can you explain that? The new form of
the poop in a box?
No, isn't there a pill that they're saying like not replaces colonoscopy? It was like kind of like the first step of colonoscopy.
Oh, like a pill cam where you like swallow the camera and then some poor soul has to look at hours of video footage of your digestive tract.
Yeah.
Yeah. So pill cam's great. Definitely a role for them. The challenge with that is you still have to take a bowel preparation, but you don't get the nap.
Okay.
Right.
So you have to do all that. And then you do it again if they
right. And if there's something that so the next step for any of those tests being abnormal or equivalent is a colonoscopy. So if you find yourself, holding a positive Cologuard test in your hand, you need a colonoscopy.
Yeah.
If you got a CT enterography, right? Like, oh, can I just like lay in the MRI scanner and you guys like, sure. But if I see something abnormal or equivocal, you get a colonoscopy and it can't see small polyps, and removing those can prevent cancer in the future.
Yeah. I think people think that MRIs sometimes are like the end all be all. Like, I mean, there's so many images in there.
We talk so much about rectosteel.
Yeah. And it's not the end all be all.
No,
yeah.
Not at all.
I mean, it can kind of just give you some ideas of what's going on. But.
Yep. We talk about toolkits as like ways to kind of treat medical problems, but these are also tools with specific functions for diagnosing problems too.
Yeah. Last question, a little off topic, but you hear more, or at least maybe it's just me, but a lot of younger men, like in their not a lot, excuse me, but younger men in their 30s kind of getting late stage colon cancer.
Mhm.
What do you think?
So the honest answer is we don't know why young people are getting more colon-rectal cancer. So you can Google it and see 100 different hypotheses, but the answer is I don't know. And that's why, as far as early onset disease, so age less than 50, age less than 45, depending on what guidelines you're looking at, we have to be listening. You have to be listening to people that come to your office. You have to be listening to your friends and family. You have to be willing to say, like, hey, bleeding out your bottom is not normal. And you got to get that looked at. It's worth the inconvenience of interacting with the medical group to make sure that you are healthy and safe. We are losing too many like beautiful young lives who they have a role in their families, in their workplace, in their friend groups, like because someone told you it was a hemorrhoid, because you didn't ever want to say anything.
They're not
because you thought it couldn't happen to you. And like, I mean, I would rather do negative colonoscopies all day long and do jumping high fives with you afterwards and just be so proud that you sought care.
Yeah.
You can deal with the hemorrhoid stuff later. Just make sure it's not anything serious.
I haven't told you this, but I'm a cancer survivor myself.
I did not.
And so basically, I remember it was in 2019. I had a lump above my collarbone and ended up being Hodgkin's lymphoma. I'm fine. I'm good. It's been 4 years. But the point was that my first doctor kind of dismissed me. And then I went back again and it was kind of dismissed. And then I went to somebody else. I was like, I need this biopsy. Like, I need this biopsy. And it was like, as soon as, and the initial scan missed it somehow. It was a golf ball sized tumor. But my point is that I thought it was stupid that I was getting it looked at initially.
Mm-hmm.
I thought it was dumb. I had just started my business and I was like, oh, this is a waste of $300 or whatever it was. Why am I here?
Yeah.
And please, please, please just do it. Just get it checked out. And then it's just, off your bucket list of things to do. And then you don't have to worry about it. Cause I mean, even just that low grade fear of worrying about it can take a lot of stress on you too, So yeah, props to you for saving people, saving cancer, for saving people from cancer yeah. So any fun things that you would like to add at the end here? Like any stories or any, I mean, I'm sure, what is like the most common thing people ask you when you tell them what you do?
Oh, it's always, what is the strangest thing you've removed from someone's rectum? A toothbrush? The vibrating ones.
Oh, okay. Nothing else?
A dog Kong.
A what?
A dog Kong. Like, would you put peanut butter in and give to your dog? It's like shaped like a pyramid.
Oh, I didn't even know that those were a thing.
And anal intimacy can be an important part in relationships, but please use designated toys with handles or flanges.
Yeah, and lots of lube.
Yeah.
The rectum is not lubricated the way the vagina is.
Correct. Yeah. Handles and flanges, please.
Cool.
Yeah.
Well, thank you so much for coming. Or I came here, so.
Thank you for having me. This is it. If one person who's having bleeding gets a colonoscopy because of our chat, and if one person who's been suffering with what they thought was like eternal damnation of hemorrhoids gets it evaluated, pops a band on that sucker and feels better, ooh, my job's done.
Yeah. So thankful that we were able to chat. You're
Thank
so fun.
you.
All right.
Yeah, you guys are welcome to reach out to me if you ever have questions. I'm on Twitter.
You're on Twitter?
Yeah.
What's your Twitter handle?
@cuttinghumor. I'll have to open it up, but I would.
Or I can also tag where you're working too.
Yeah. Come and see me if you're in Austin.
Cool. All right.
Sweet. Thank you.